Welcome to the Explainer. So if you've ever looked at a complete blood count report and felt like you were just staring into an alphabet soup of random acronyms, trust me, you are absolutely not alone. But today, we're going to fix that. We're going to take that dense, intimidating grid of data and turn it into an actual clinical superpower for you. We'll be walking through a master blueprint that takes you right from basic parameter definitions all the way through some pretty advanced clinical reasoning.
Okay, so here's our game plan. First, we'll quickly tackle the parameter glossary. Next, we'll map out the pathological patterns, and then finally, we're going to put everything to the ultimate test in our clinical case bank.
Section 1. The parameter glossary. Let's get our foundational definitions sorted out first.
All right, let's kick things off with the erythrogram. Basically, the whole story of our red blood cells. Now, just a quick aside, reference ranges will always vary slightly depending on the specific hematology analyzer your lab uses, but the core concepts are universal. Looking at the main metrics, the total RBC count gives us the absolute mass of those red blood cells, while hemoglobin, or HGB, is really your most accurate measure of the blood's actual oxygen transport capacity. Then you have the HCT, or PCV, which simply tells us the percentage of the total blood volume that is actually made up of red blood cells. But here's where it gets interesting. Pay really close attention to the MCV, the mean corpuscular volume. This tells us the physical size of a single red blood cell. So when MCV goes up, what we call macrocytosis, it's very often a huge sign of active bone marrow regeneration. Why? Because those newly minted immature red blood cells are literally just physically larger than the mature ones.
Moving through the rest of the erythrogram, you really want to keep an eye on the MCHC and the reticulocyte count. MCHC measures hemoglobin concentration. If it drops down, meaning the cells are hypochromic, it usually points to either marked regeneration or a severe iron deficiency. But hey, note this, because it's a huge trap. Biological hyperchromia, an actual, true physiological increase in MCHC, does not exist. No way. It is almost always just a machine artifact caused by lipemia or hemolysis in the sample. Finally, look at the Reddit count right there at the bottom. This is the absolute number of immature, non-nucleated red blood cells. Honestly, it is the ultimate undisputed test of how well the bone marrow is actually functioning.
Okay, let's transition over to the leukogram. We're starting with the first responders, the white blood cells. Now, total WBC count is definitely helpful, but you must always interpret it alongside the differential. Neutrophils? Those are your fully mature frontline soldiers battling against bacterial infection and acute tissue damage. But take a look at the band neutrophils. These guys are the immature cells. When you see a spike in bands, it indicates a severe left shift. Basically, acute inflammation is driving tissue demand so insanely high that the bone marrow is literally forced to release unfinished, immature cells straight into circulation just to try and keep up.
Now, the details really matter when we look at the rest of these white blood cells. Lymphocytes are the ones handling your acquired immunity. Monocytes, well, they're your large, cleanup crew phagocytic cells. And seeing them show up is a massive indicator of chronicity. Think chronic inflammation or ongoing tissue necrosis. Then we have the eosinophils. These are highly specialized responders. If you see those numbers jump, you should immediately be thinking about three things: parasites, allergic reactions, or even Addison's disease. Oh, and basophils? They are super rare histamine-filled cells that tend to just travel right alongside those eosinophils.
Wrapping up our glossary, we have the thrombogram. Now, we all know platelets are in charge of primary blood clotting, right? But here is a really cool advanced clinical tip for you. Do not ignore the MPV. That's mean platelet volume, and the PDW, platelet distribution width. A high MPV paired with a high PDW heavily supports active bone marrow regeneration. It basically tells us that giant macroplatelets are mixing in with the normal-sized ones because the marrow is just working overtime to replace platelets that are being rapidly destroyed out in the periphery.
Do not look at single arrows. Look for patterns. Seriously, if you take away only one thing from this entire explainer, let it be this golden rule. Staring at just one high or low value is a one-way ticket to the wrong diagnosis. You absolutely have to look at how these parameters move together. It's like a giant puzzle. And honestly, this is the perfect mindset to have as we finally take the training wheels off and start applying this knowledge.
Let's see exactly how this builds by visually contrasting two major patterns side by side. On the left, we have regenerative anemia. Here, the bone marrow is vigorously pumping out these large, immature reticulocytes. So what's the resulting pattern? Well, MCV goes up because the new cells are physically large, MCHC goes down because they literally haven't finished making their hemoglobin yet, RDW goes up because you now have a messy mix of different cell sizes, and of course the Reddit count is high. Now, contrast that with the right side, non-regenerative anemia.
The MCV, MCHC, and RDW are all completely normal, but the red count is dangerously low. This is the alarming, classic signature of bone marrow failure or a complete lack of signaling. Okay, now let's look at the white blood cell patterns. I want you to memorize the SMILD mnemonic for the stress or cortisol leukogram. SMILD stands for stress means monocytes increase, lymphocytes decrease, eosinophils decrease. Cortisol literally traps those lymphocytes right in the lymph nodes. Next, compare that to the physiological epinephrine leukogram. This is basically an adrenaline rush that simply washes marginated cells right off the blood vessel walls into the bloodstream, causing both neutrophils and lymphocytes to temporarily spike. And finally, the inflammatory left shift, where severe tissue demand outpaces the marrow's production line, pushing those immature banned neutrophils straight into the blood.
Section 2, the clinical case bank. Get ready for 20 rapid-fire scenarios.
All right, let's hit the virtual clinic floor. I'm going to run through these fast. See if you can spot the pattern in your head before I reveal the diagnosis. Cases 1 through 5. Bruno has a low MCV, low MCH, high RW, but low reticulocytes. That's a microcytic, hypochromic, non-regenerative pattern, meaning iron deficiency anemia from chronic GI bleeding. Next up, Luna the poodle. She's collapsed, but her blood work shows high lymphocytes and eosinophils. The diagnosis? Addison's disease. Luna's dangerous lack of a stress leukogram, despite being in a critical state, is the absolute hallmark here. Moving on to Tiger. He collapsed with pale gums, a totally normal hematocrit, but low total protein. That points to acute hemorrhage, since total protein always drops before the hematocrit has time to catch up. Then we have Milo. Severe thrombocytopenia and high total protein from a tick infestation, pointing straight to canine monocytic ehrlichiosis. And finally, Simba presents with a severely low hematocrit, high MCV, and massive reticulocytosis. That's a highly regenerative hemolytic anemia, diagnosing babesiosis.
Continuing right along sequentially with cases 6 through 10. Case 6, Shadow. Low WBCs, low hematocrit, and low platelets with zero signs of regeneration. That is bone marrow aplasia, or pancytopenia. Case 7 is Mittens the cat, presenting with a massive isolated eosinophilia, diagnosing feline allergic asthma. Now look closely at Duke, Case 8. He has low mature neutrophils but high bands. In fact, the bands actually outnumber the mature cells. That is what we call a degenerative left shift, and it diagnoses overwhelming sepsis. Contrast that with Rusty, Case 9. He has high neutrophils and monocytes, but low lymphocytes and eosinophils. That is your textbook smiled leukogram, driven by chronic cortisol from Cushing's disease. And Case 10, Leo, the hissing, angry cat. He's got high neutrophils and lymphocytes, just a classic physiological epinephrine response from being stressed out at the vet.
Keeping up the rapid-fire pacing, let's look at Case 11, Barnaby, who came in with seizures. He shows inappropriate regeneration, meaning we see nucleated red blood cells and basophilic stippling, but no actual reticulocytes. That combo diagnoses lead poisoning. Case 12, Cleo, has highly regenerative anemia with tiny epicellular organisms stuck right on her red blood cells. That diagnoses feline infectious anemia. Case 13, Rex, is bleeding post-heat stroke. He's got low platelets and schistocytes, those are fragmented red blood cells, diagnosing DIC. Case 14, Peanut, a stunted little Yorkie. He has a microcytic, normochromic, non-regenerative anemia. This points directly to a portosystemic shunt, altering his liver's iron metabolism. And Case 15 is Oscar. He has a dangerously high hematocrit of 75%, but totally normal oxygen and EPO levels. That diagnoses polycythemia vera, which is a primary bone marrow overproduction disorder.
All right, let's finish this clinical gauntlet strong. Case 16, Sophie. She has non-regenerative anemia, extremely high total protein, and extreme rouleau formation, where the red blood cells stack up like little coins. That diagnoses multiple myeloma. Case 17, Buster, has a massive left shift flagged by the machine, but wait, he's perfectly healthy. The blood smear shows peanut-shaped neutrophils. This is actually the Pelger-Hewitt anomaly, which is just a totally benign failure of cell segmentation. Case 18, Zeus, has high eosinophils and basophils, heavily pointing to heartworm disease. Case 19, Bella, presents with jaundice and widespread target cells and echinocytes on her smear, diagnosing end-stage liver cirrhosis. Finally, Case 20, Winston.
He came in with a neck bite wound and has a huge white blood cell count of 25, but it's entirely mature neutrophils with normal band levels. This just proves his marrow is easily handling a localized abscess without being overwhelmed at all.
And just like that, we've completely decoded the alphabet soup. You've seen the core definitions, you've grasped the vital pathological patterns, and you've successfully survived 20 rapid-fire cases on the clinic floor. You now possess the structured blueprint to translate raw, intimidating data into immediate, actionable diagnoses. So, the question I want to leave you with today is this: how are you going to apply this clinical blueprint to spot life-saving patterns in your very next critical patient? Keep looking for those patterns, trust your training, and never, ever let single arrows fool you again.